Hello, everybody, and welcome to Grand Rounds. Today we have the pleasure to have Dr. Siddharthan. I'm sorry if I'm mispronouncing your last name. He completed medicine in the University of Miami. Then he completed internal medicine residency at Yale, where he also served as chief of medicine, and then completed pulmonary and critical care training in Johns Hopkins. His academic career has ranged from Hopkins to Yale, and currently he is assistant professor of medicine. So welcome, and thank you very much for being here with us.
Thank you, Dr. Diaz, and you pronounced the name right. My name is Trishul Siddharthan. I'm one of the assistant professors back in Miami in pulmonary and critical care. The title of this talk is The Global Burden of Lung Disease and Disease Management Strategies. I have no disclosures. The following organizations funded my work in addition to NHLBI, which I left off here, and we'll start with a clinical case. And so when I was a fellow, I saw a 33-year-old gentleman who presented in my clinic with shortness of breath. He noticed progressive shortness of breath, mostly in his mid-20s. He says he was no longer able to play soccer, and soccer is one of those sports that's really great in terms of assessing cardiopulmonary ability. He can actually tell me how long he could play in a match and how that degraded over time. He had moved from Puerto Rico after Hurricane Maria, and he was told he needed to see a lung doctor by his primary care physician, which is how he ended up seeing me. He stated no cough, occasional asthma. He had a major hospitalization, states he was close to being intubated, multiple ER visits, which isn't unusual for someone who had severe asthma as a child. But the interesting thing is he told me he had emphysema and was diagnosed with COPD 3 years prior. As someone that's 30 years old of age with the diagnosis of COPD, it was highly unusual. I thought he was mistaken. He had been prescribed Advair by his primary care physician, though stated he was unable to afford, states seasonal allergies, as well as recurrent childhood infections. And pertinent to his social history, he was a lifelong non-smoker. He worked preparing food in a kitchen previously in Puerto Rico. He lived in a rural area of Puerto Rico, though states no biomass fuel exposure, it was mostly LPG cooking. And so I ordered a CT scan, ordered PFTs, and sure enough, the PFTs came back with a severe COPD. This is a CT scan for those sort of not familiar. On the, let's see if I can get a pointer out. On the left over here, so it's sort of preserved lung tissue. On the right, we have emphysematous changes in the apices. It's predominantly apical. There's some bronchiectasis over here on the right middle lobe, and then going down relative sparing at the bases bilaterally. I ordered alpha-1 levels, which were normal. We additionally did a TB test on him. His T-spot was positive, though on bronchi had a negative TB. And so this is an individual with really no exposure to tobacco smoke and early on-stage COPD. And in a population level, it is relatively rare among a population. Copenhagen Heart states 1% of individuals that were non-smokers had COPD. Gold stage 2, which would be mild to moderate disease, and northern Sweden, that was about 3.5%. But BOLD, which is the burden of obstructive lung disease that included countries in low and middle income settings in South America, Africa, as well as Asia, had a higher prevalence. And so for gold stage 1, about 6.6%, and about 5.6% of their entire cohort met the criteria for gold stage 2. And when we look at individuals with COPD, and so these are individuals that have a diagnosis with COPD, on the y-axis is proportion of patients with COPD who are non-smokers. On the x-axis are countries. Even within the United States, the prevalence of non-smoking among individuals with COPDs is about 25%. And that goes all the way up to 45% in South Africa through the BOLD cohort, where there's a different set of exposures. And so the objectives of this talk are to characterize the prevalence and risk factors for chronic respiratory disease in global settings. And this has a unique importance, because 90% of the morbidity and mortality related to COPD occurs in these settings. Globally overall, even in the United States, we're seeing a decrease in the prevalence of smoking and an increase in the prevalence of COPD attributable to non-smokers. We'll additionally assess the strategies for prevention, diagnosis, and management in research-limited settings, and determine how research in global settings can be translated to high-income settings and inform our daily practice here in the United States. And so this diagram is a variation of the classic Fletcher-Pettigrew diagram. You might remember this from medical school. On the y-axis is FEV1, and this is the amount of air you can expel in 1 second on PFTs, and on the x-axis is age. And lung function development begins intrautero. About the 4th week of development, small saccular outgrowths begin to form the nascent left and right bronchi. It continues from birth all the way up to the age of 25. And at the age of 25, you have sort of a steady state of lung function decline until death. And so this solid black line above represents healthy lungs. This line below represents lungs exposed to various risk factors and lung function subsequent to various risk factors. And in the case of our 33-year-old gentleman who I saw in clinic, this represents the lower limit of normal. And so when you become symptomatic. A number of risk factors, evidence supported in low and middle income settings as well as high income settings are related to decreased lung function growth intrautero and in childhood, and then finally accelerated lung function decline after the age of 25. Micronutrient deficiencies, so vitamin A that was studied in Nepal, have shown decreased lung function growth intrautero. Malnutrition, the classic cohort is the Dutch famine cohort from 1944 to 1945 during World War II. Smoking during pregnancy has been well studied to result in lower lung function gains at birth, and hypothetical risk factors includes biomass fuel smoke. Respiratory infections, poorly controlled asthma, and tobacco smoke during adolescence result in decreased lung function gains. Currently, we're studying biomass fuel smoke, and there's some limited evidence to suggest ambient air pollution from tobacco-related smoke, from traffic-related air pollution can result in decreased lung function gains. And then in adulthood, tobacco smoke, biomass fuel smoke, occupational exposures, and comorbid medical conditions have all been shown to accelerate lung function loss. And if there's one thing to take away from this slide is to understand that risk occurs across the lifespan of individuals, and that risk factors are heterogeneous and occur and interact at various points across the lifespan. And so this slide is actually primarily for trainees in the audience. And so this is Mulago National Referral Hospital in East Africa. And so I had the opportunity to work there as a resident. And when I worked there, the average life expectancy had increased to mid-60s, 64, 63, from the mid-40s about 10 years prior. And that had been largely attributable to the widespread dissemination of antiretroviral therapy. But what we did see during that time as life expectancy increased was a rise in non-communicable diseases like end-stage renal disease, COPD, and the disease sort of presentation or phenotype was distinct and different. Those individuals that had end-stage renal disease were presenting much younger and not with the traditional risk factors like hypertension, diabetes. And among individuals with COPD, it was middle-aged women that were predominantly non-smokers. And so that led me to sort of start asking questions is what is different about this cohort? What is unique about these individuals with COPD who have not smoked, and particularly in these settings? And Mulago National Referral Hospital is a tertiary care center. It receives patients from Rwanda, all over Uganda. To really ascertain risk, you have to go to a population level. And so actually go to these individuals' households, individuals that are exposed, not exposed, with disease and unexposed disease. And so the first study we sort of looked at was lung function in Nakaseke and Kampala. And we did this study in Uganda and East Africa, which had a population of about 30 million at the time. Now it's about 43 million. And we wanted to look at the risk of urbanization and risk factors related to urbanization and chronic respiratory disease. And this is a graph that can be sort of, this is a presentation or a picture that is similar across settings in East Africa and probably throughout the world in South America as well as Asia. Kampala on the left is an urban population. This is actually one of the census tracts that we conducted surveys. We took 25 areas within Kampala and 25 areas in Nakaseke and did population attributable sampling. And you can sort of, looking just from this satellite view, you can sort of think through some of the risk factors that are pertinent to the urban setting and the rural setting. In Kampala, there's increased rates of asthma, recurrent respiratory infection, tuberculosis. In Nakaseke, there's increased rates of malnutrition, as well as indoor household air pollution. And what we found is 20% or 1 in 5 individuals had one of the respiratory diseases we were looking for. And so if this left graph is crude prevalence. This right graph is age-adjusted prevalence. We looked at COPD, asthma, chronic bronchitis, and restriction on spirometry. The dark lines are urban and the light lines are rural. There's an increased prevalence of COPD in the rural areas, 6.1% compared to 1.5%. There's an increased rate of asthma in the urban areas, 9.7%. Compared to 4.4%. There's not a statistically significant difference in chronic bronchitis or restriction, but there was an increase sort of trend in the rural settings for both entities. If we look at the next graph, this left plot is COPD, this right plot is asthma. These are various risk factors for gender, BMI, household size, secondary education, rural setting, tuberculosis, HIV status, and smoking. And this is population attributable fraction. And so population attributable fraction is described as the fraction of all cases of a particular disease or adverse condition that is attributable to specific exposure. And so in the case of COPD in Uganda, close to 55% of all cases were related to rural status. And similarly in asthma, 40% of cases were associated with an urban setting. And although the prevalence of tuberculosis was low, it is the single most important risk factor. And so if we think to our gentleman that we saw in clinic with apical emphysema, there was a high likelihood that that was related to tuberculosis or prior history to tuberculosis, and ruling out tuberculosis was sort of at the top of my differential. And so individuals that had tuberculosis compared to not were typically one standard deviation beyond the mean difference in lung function, both in terms of forced expiratory value in 1 second, forced vital capacity, and finally the ratio that we utilize to diagnose COPD. And so there's a number of limitations with cross-sectional studies, because we don't have longitudinal data to understand the role of urbanization or the longitudinal effects of urbanization in cardiopulmonary outcomes. And the second thing is really covariance. And so in our rural setting in Uganda, over 90% of individuals use biomass fuel, charcoal or wood for cooking. In the urban population, 20% uses clean fuels such as electricity or LPG. And so, one of the studies that we're currently ongoing here in Uganda, this was a recently funded R01, and there's another study in India is actually looking at longitudinal migration over a course of 5 years in population cohorts like this and the effect of ambient and household air pollution on cardiopulmonary outcomes. To answer the question of covariance, we have to actually look at a sort of a larger sample across settings. And so the GrantSat multi-cohort network is a network of 13 resource-limited settings where we have detailed population level data on spirometry as well as demographics in South America, Asia, as well as Africa. The cohorts consisted of NHLBI funded studies in Peru, Argentina, Chile, Uruguay, and Bangladesh, the Fogarty funded study that I showed you in Uganda, as well as another EU study, funded study in Uganda as well. And all in told, this was about 12,396 participants in 6 countries and 13 resource-limited settings. The average age was 54.9 years, about half were women, and 38% stated daily biomass fuel exposure. And the relevance here in the United States, and particularly in Miami, is biomass fuel is actually utilized by about 3 billion people globally, and 40% of all households, both in high and low-income settings, utilize biomass fuel. In the United States, the actual prevalence of biomass fuel use in Appalachia is extraordinarily high. COPD was defined as a post-bronchodilator ratio of less than the lower limit of normal. And these large cohorts allow for numerous analyses that help us inform risk factors related to COPD. And so we looked at household air pollution, socioeconomic status, asthma prevalence, tuberculosis, and finally malnutrition. And so overall, the prevalence of COPD in the cohort was 8.8%. On the y-axis is our sites included in the trial. It's dichotomized by women and men and stratified furthermore by severity. And what this graph really allows us to see is the different presentation of diseases by different contexts. And so in MATLAB, Bangladesh, and in Dhaka, where there's a higher prevalence of smoking, you have more severe disease. In Tumbes, which is a semi-urban area in Peru, we had a low prevalence of disease, particularly among women, and very limited severe or very severe COPD. And going through our initial study, our interest our primary interest in developing this cohort was actually to identify the association of household air pollution. And so as described, it's utilized by 3 billion people. 90% of households in low and middle income settings use this for heating their house or electricity needs daily. Prior to the study, there had been a number of meta-analyses as well as observational cohorts, smaller in nature, that have found a positive association between biomass fuel use as well as obstruction of spirometry. Over our cohort, we had a 41% increase, and so the odds ratio was 1.41 for obstruction on spirometry. And as expected, this was predominantly among women, and so women tend to be the primary cooks in the household. Individuals with biomass fuel use daily stated more severe COPD and had more symptomatic disease. And when we look at the prevalence across decile, and so the y-axis is prevalence, the x-axis is age is decile, you see a differentiation between the curves. This red curve is biomass fuel daily. This blue curve is clean fuel, so that's LPG and electricity. And you see an initial split, which actually increases with age up to the age of 70 in our cohort. We found that socioeconomic status additionally was associated with increased rates of COPD. And so socioeconomic status, particularly in low and middle income settings, is hard to differentiate it. And additionally, in the United States, many individuals, particularly in the settings where I've worked, are sustenance farmers. They can't quantify household income daily, let alone by year. Secondary school, household size, and household income are proxies for socioeconomic status. But as you can see, sort of one is our reference point for the odds ratio. These risk factors cross over 1. Though when using principal component analysis, we can take the various contributions of these individual variables and stratify by the 25th and 75th percentile. And what we found was when combining SES into a composite index, lower SES accounted for an odds of 1.23, even after controlling for subject-specific factors and environmental exposures. And when thinking back to sort of lung function over the lifespan, low SES or socioeconomic status is associated with all these risk factors independently: micronutrient deficiencies, malnutrition, respiratory infections, poorly controlled asthma, and finally exposure to noxious stimuli. This data was replicated by the BOLD cohort, and so this is a graph looking at wealth index, and so they sort of took the inverse of what we did and found that individuals that had a higher wealth index were protected when looking at obstruction of spirometry. Similarly, low body weight is associated with COPD, and this data had been known for a while. The BOLD index, which many of you might be familiar with, is an index used to stratify risk among individuals with COPD. They use a cutoff of about 21 for their BMI. So individuals less than 21 have a higher risk, 1.23 increased risk of mortality with COPD. In lower and middle income settings, it's different, and that's partly due to the fact that the obesity really hasn't increased in low and middle income settings in the way that it has done in high income settings. And so we found an inflection point of around 19.8. And so individuals that had a BMI less than 19.8 were 2.28 times more likely to have COPD compared to those that were higher. And this graph just shows that it is consistent across sites. And so across all of our sites, we found similar distributions in BMI and lung function, looking at FEV1, FVC, as well as the ratio. What about tuberculosis? And so this is a distribution of prevalence of tuberculosis across sites. And although tuberculosis and COPD, the prevalence was heterogeneous across sites, when we look at individual subjects, previous tuberculosis prevalence per 1,000 on the x-axis and COPD prevalence per 1,000 on the y-axis, we found a correlation between the prevalence of tuberculosis and COPD. And that's further backed up on lung function, subject specific. And so the prevalence of COPD on this first graph, it differentiates. This dark line is going to be tuberculosis history. This dotted line is no tuberculosis history. FEV1 is differentiated, similar to the findings in Uganda, FVC, as well as FEV1 over FVC. this presentation of COPD may be distinct and different. And so asthma COPD overlap is an entity that's been well studied in high income settings. And so these are individuals that have fixed obstruction of spirometry, as well as evidence of asthma or airway reversibility and hyperactivity. In our cohort, we found that a total of 13.6% had asthma only, 4.8% had COPD only. But among those with ACOS or asthma COPD overlap, 31% accounted for severe obstruction. And so individuals that had asthma and COPD overlap had more severe disease and had more deleterious outcomes. And this is consistent with data across sites in low and middle income settings, and distinct and different really from the data in high income settings, though the prevalence is the same. And so what does that mean in terms of strategies for prevention, diagnosis, and management, both in these settings as well as in high income settings where we see populations with relevant exposures and risk factors? And so this graph is important. This picture is important for a number of reasons. This represents the top as sort of the availability of salbutamol. And so this is sort of a short-acting beta agonist, which is the mainstay of treatment really for mild asthma and frequently prescribed for patients with COPD, as well as the affordability of salbutamol. The red areas mean that it's less, sort of dark red's less than 5%, white means there's no data available. And across the board, there's a limited availability of salbutamol. And among those where we have data about affordability, it is highly unaffordable. And the importance of this is inhalers are the mainstay of treatment for individuals with both COPD as well as asthma. As evidenced by the case prior, even in the United States, inhalers are frequently unaffordable, and more so, they're complex instruments. And so they have to deliver a fixed dose over the course of the entire lifespan of the inhaler and require education in terms of use. And so starting off, the question is, do novel risk factors and settings warrant different screening and treatment approaches? And so in 2017, the U.S. Prevention Service Task Force recommend against screening for COPD. And within the respiratory community, this has been sort of a highly contentious issue. There's a number of trials ongoing, which I'll speak to, that are aimed to provide further evidence. And the reason why USPSTF recommended this is A, there was insufficient data, but B, the data showed that through screening approaches, we were identifying milder cases that did not necessarily require treatment. And so we just completed a multinational trial in 3 low-income settings to assess the effectiveness of screening tools as well as self-management action plans. And so we looked at Peru, where the GDP is 6,661. This was this is 2019 data. Population was 30 million, and the life expectancy of about 74. Uganda, where the GDP was 571. Population was 37.58. Life expectancy was 53. And Nepal, with the GDP was 694, population was 27, life expectancy was 67.98. And the objectives of this study were to determine the diagnostic accuracy of case-finding questionnaires with PEF and assess the clinical effectiveness of action plans and management. And the real importance to this is any case-finding questionnaire has to be related to relevant risk factors. And so this was actually a lung function questionnaire developed by Barbara Yan, who's actually now the director of the COPD Foundation, which is based out of Coral Gables, in 2010. And so she developed a questionnaire, their group developed a questionnaire of 5 items that with relevant risk factors. So how often do you cough up mucus? How often does your chest sound noisy? How often do you experience shortness of breath? How many years have you smoked, and what is your age? Fernando Martinez in 2018 actually added peak expiratory flow to a similar questionnaire and found a relatively good sensitivity and specificity, a sensitivity of 95.7% in terms of detecting COPD and a specificity about 67.8%. We created a similar tool using machine learning algorithms to identify unique risk factors based off the previous data that I've shown you. And the aim was to see the performance of these 3 instruments, capture, LFQ, colon, peak expiratory flow individually for these global cohorts. And so a total of 26,000 individuals were approached. We recruited 11,000 individuals, and of those 9.4% had COPD, or 1,000 individuals in total. And what we found was a good performance for screening for COPD. And the important part of this is the access to spirometry. And so in many areas, A, in the United States, but B, globally, there's limited access to spirometry. And so ultimately, and as the slides will continue to show, is this data is context specific and screening is context specific. The COLA questionnaire, which was sort of pertinent specifically to low and income settings, had a diagnostic accuracy of 82.73%. And as you see on the graphs, this is sensitivity and specificity in the area under the curve. We had similar operating characteristics across the 3 sites. And so this is the diagnostic performance of the 3 screening approaches in colon and specific. The green represents true negatives, the red represents true positives, the yellow represents false positives, and the white represents false negatives. And overall, the cost per 100 people screened accounted for $303 in Nepal, so $3 per person, $2 per person in Uganda, about $1.5, about $15 per person in Peru, and overall about $7 per person, which is well within screening thresholds for these countries. And more importantly, by developing questionnaires that are context specific, we were actually able to identify more severe cases of disease and disqualify milder cases for subsequent spirometry and treatment. The second part of the study was to assess the clinical and cost effectiveness of COPD action plans in the setting in terms of health-related costs and benefits and productivity across the wider healthcare system. And self-management active plans are utilized in the respiratory settings frequently. And so they're frequently actually used in asthmatics and individuals with moderate to severe asthma, as well as individuals with severe COPD. We train our patients in how to understand symptom severity and when to proceed to the hospital. And so this is a self-management action plan that was developed in the context of this trial. This would be a yellow setting, so an individual that was having an exacerbation. The advice is to continue taking maintenance daily medication, to utilize quick relief inhalers, start oral steroid tablets, and contact a local healthcare provider. This is a community health care worker if your symptoms don't improve. In the green setting, we have a similar graph, a picture that looks at basically continuing daily use and stopping smoking. And in the red setting, we advise proceeding to hospitalization. And self-management action plans have been well studied in high-income settings. This is Jean Verbeau's work out in Canada and Quebec. He looked at 9 sites in Quebec in 2003. And in Canada, they have a nationalized healthcare system with a very adequate sort of social support. And a significant component and portion of this study, it was multimodal, was actually case management outside of the hospital. And so a caseworker would call participants after they've been discharged from the hospital or from the clinic setting, ensuring that they were adhering to their management plan. And at 100 days, there was a 39.8% reduction in the intervention group in those individuals that had action plans and active case management compared to the usual care group. Though in subsequent meta-analyses, the data was highly heterogeneous. And it goes back to this concept of context. And so this was a paper published now 2 years ago, actually out of Baltimore. And so they did an RCT using a very similar process to John Verbeau's work, looking at self-management action plans at discharge. And as you can see, this is the probability of events. And so lower Kaplan-Meier, the curve on the Kaplan-Meier curve is worse. The intervention group is flipped over here. And so individuals that were given a self-management action plan were more likely to be seen in the ED. And that actually probably speaks to the episodic care in the United States and the fragmented care more so than anything else. And so self-management and the utilization of plans and proceeding to the ED is highly context specific. So the tail end of this talk aims to determine how research in global settings can be translated to high-income settings, and why do we need to do studies in Uganda or Bhaktapur, Nepal, or Lima, Peru, in order to inform the care of our patient that we saw in a clinic in Baltimore 5 years ago. And so there's growing evidence that these risk factors result in novel phenotypes and perhaps novel endotypes. And so an endotype is basically a distinct disease pathogenesis as a result of a distinct pathway of injury. And so alpha-1 is the classic endotype in COPD. And so individuals with biomass COPD have an airway predominant phenomena. they have increased cough, phlegm, and symptoms of chronic bronchitis compared to those with tobacco smoke. They have decreased rates of emphysema. And importantly, they have increased rates of airway hyperreactivity, bronchodilation, and methacholine hyperresponsiveness. And this is distinct and different from individuals with tuberculosis-related COPD. And so that represents more of a fibrotic burnt out process. Individuals with biomass-associated COPD have increased airflow obstruction, though it is less severe than that of smokers. There's a lower quality of life and more hypoxemia than smokers. And this is actually a very exciting sort of computational fluid dynamic model developed by one of my collaborators at Johns Hopkins using particle size deposition. And so this red area is PM10. These blue areas are sort of ultrafine particles. And this is a representation of the trachea as well as sort of the second or third generation of the large airways. And as you can see, the larger particle size in red deposit more in the oropharynx and sort of in larger airways, whereas sort of the ultrafine particles or the lighter particles go more distal. And this is data that's been well described and well known. The prevalence of cancer among smokers changed fundamentally in the 1950s and 60s from a more central disease process to more peripheral disease process. And the reason why is filters. And so filters on cigarettes filtered out those heavier particles, and you had a further distribution of carcinogens in the distal airways and more peripheral disease. And so going back to our data across our cohorts, this is backed up in epidemiologic data. And so in MATLAB Bangladesh, as well as Dhaka Bangladesh, where you have some of the highest rates of smoking there among men, there was a higher rate of more severe emphysema. And so this is going to be FEV1 less than 50%. Then in individuals that are predominantly exposed to biomass fuel smoke. And so take an example is Nakaseke over here, and then the other is rural Pune over here. On necropsy, individuals with biomass fuel smoke have a distinct pathogenesis. And so CS represents cigarette smoke, BS is biomass smoke. There's increased goblet cell hyperplasia among cigarette smokers that we don't see in biomass smoke. But there is increased anthracosis. And so that is pigment deposition, both in the small airways as well as the intima of the airways. Lastly, there's also increased intimal thickness, particularly in the pulmonary vasculature. Yet we are still severely limited by the recommendations, and we don't have no clinical data related to COPD among these unique phenotypes. This was, I did a literature review, and this is actually going to be updated. We have a paper that will be coming out from the ATS-ERS in terms of guidelines in low and low-income settings. But the last review that I could get was from 2001 that was published in Bolhu that recommended a modification of the GOLD guidelines. Inhaled salbutamol as a first step, inhaled ipratropium as sort of a second step, and then finally add on theophylline at low doses and then potentially an ICS. Going back to the point sort of at the beginning of this part of the talk, in India, one inhaler of salbutamol and one inhaler of beclomethasone costs about 1.6 to 2.3 days wages for the lowest paid government worker, and 80% of the population it doesn't even make that in terms of wages. In sub-Saharan Africa, those cost estimates go up fourfold. Theophylline is a drug that some in the group that's listening right now might be familiar with. It has been around since 1890s, and so in 1895 it was sort of first extracted and synthesized. In the 1920s, we actually understood the bronchodilatory properties of theophylline, and so this is actually a graph from Peng and colleagues' work looking at FEV1 and theophylline concentration. It's known to relax smooth muscles. Its mechanism of action is phosphodiesterase inhibition through increasing cyclic AMP as well as a cyclic GMP. It's a potent adenosine receptor antagonist and increases bronchodilatory response greater than 10 milligrams. And theophylline used to be a mainstay for COPD, but one of the issues was the therapeutic index. And so at higher levels of theophylline concentration, there's an increased rate of arrhythmias, potentially seizures, as well as adverse effects. More recently, it's been studied for its anti-inflammatory properties. And so it decreases IL-10 and inhibits NF-kappa B. And interacts at the same level as sort of glucocorticoid receptors intracellularly. And so corticosteroids work through glucocorticoid receptors through histone deacetylase, and that results in sort of a decrease in NF-kappa B and a distal inflammatory cytokines, including IL-8, sputum neutrophils, myeloperoxidase. Low-dose theophylline has been sort of looked at with COPD and add-on therapy. The recent TWIX trial, which came out last year, looked at it as add-on with inhaled corticosteroids with the aim of potentiating the glucocorticoid receptor antagonism. That was a negative study. But as monotherapy, there is a potential that it worked. And so the low-dose theophylline trial, and I believe the University of Miami was one of the recruitment sites as for the ACRC, showed that low-dose theophylline monotherapy might actually work, particularly in patients unable to afford inhaled corticosteroids or short-acting bronchoagonists. And so we're currently conducting a pilot randomized controlled trial in Uganda, where we're actually looking at low-dose theophylline for biomass-associated COPD. This has also been looked at tuberculosis-related disease in China, with the aim of understanding and identifying subphenotypes that might be differentially responsive to therapy. And one of the important outcomes in many of these clinical trials that we're looking at is really at assessing exposure. And so this is an ultrasonic personal air sampler device, and so UPAS device. And what it does is it allows us to consistently sample personal air pollution, so identify personal exposure in participants over the course of the period of the trial. We'll be doing this at 3 different trial time points within the trial, with the aim of assessing whether or not the theophylline modifies the effect of household air pollution on lung function. And this is actually from Peru. This was another study that happened, investigation. And so in order to sort of sample personal exposure, it takes novel approaches. And so we actually sew this into aprons, and participants use these in stoves. This is actually a participant's stove or cooking area. And we ascertain what their exposure is over the course of the trial. And actually, we just started recruitment. This was sort of one of our participants in Uganda, which we enrolled just 2 weeks ago. And you can see this is a very different individual compared to individuals that we see in our COPD clinic, who are predominantly men who are smokers in their 80s and 90s. And importantly, all of these studies going forward will be measuring effectiveness. And so we will be looking at cost modeling. Fernando Martinez and colleagues up at Cornell is looking at the cost effectiveness of screening in a multi-center study in the clinics here in the United States. We are looking at cost modeling across low and middle income settings as it relates to the administration of low-dose theophylline for biomass-associated COPD, with the aim of evaluating the incremental cost effectiveness of theophylline, explore differences across settings. And in conclusion, so there's a significant percentage of those with COPD that are non-smokers, 10 to 30%. And I suspect really over the next 10 to 20 years, we will see this increase, both in the United States as well as globally. We're seeing a decrease in cigarette consumption as a result of really 40 to 50 years of public health work aiming to prevent cigarette uptake and decrease cigarette consumption. It's important to understand risk across the lifespan of individuals. And so individuals that are non-smokers, and many of the individuals we see here in Miami as well as Jackson, a detailed exposure history and assessment is important. Understanding prematurity at birth, exposures during birth, exposures in adolescence, including uncontrolled asthma, recurrent pulmonary infections, and then finally exposures in adulthood, where people work, how they cook, and how they live on a daily basis affects lung function over the entire lifespan. And it will require sort of a different approach to what we've taken for tobacco smoke, which was really a singular injury and insult. And, for many of the trials that inform our treatment and management today, the inclusion criteria was basically for greater than 40 pack years. And so reframing who we enroll in trials and how we ascertain history to inform injury and management is of the utmost importance. And lastly, COPD from unique exposures have distinct presentations with potentially differential response to therapy. And so a lot of the studies you'll be seeing coming out of low and middle income settings and to some degree high income settings aims to ascertain unique phenotypes and endotypes with an understanding of how therapy is different. And so in the case of biomass associated COPD, we hypothesize that this is more of an airway hyperreactive phenotype with more central disease progression, and some of the therapies, including theophylline and acetylcysteine, might be more efficacious in this population compared to long-acting muscarinic agents, are some of the standard therapies advocated by GOLD and are currently utilized in guidelines. And so with that, this work obviously includes a number of investigators globally, and this work actually we have to always thank participants and the tens of thousands of participants that have participated in the studies that I presented today. And with that, I can take any questions.
Trishul, thank you so much. First, thanks for being here in Miami and joining our faculty. We're so pleased that you're here. And this really was a tour de force, grand rounds, showing us a combination of clinical science, clinical medicine, global health, and health disparities research. So really it hit almost everything. And great grand rounds. Thank you. As people are developing their questions, and I urge everyone to look in the chat to get the link for the CME and MOC. The question comes, it seems as though COPD really starts or can start even in the womb. And the question is whether you've been able to find in these large cohorts individuals that might be protected from COPD despite exposure. And have we learned anything in those instances about protective genotypes or something that might go to help us learn how we might affect the outcome of the disease?
Absolutely. And now, as many of you guys know, the NIH requires a sort of enrollment over the lifespan for this reason. It's a priority of NHLBI to identify injury. And really all investigators have been talking about this really for the past 5 to 10 years, is not necessarily looking at COPD at the tail end, but thinking about COPD intra-utero and in childhood with an understanding of identifying distinct groups that are potentially protected from exposures. And the problem with a lot of this work is we just don't know as yet. And so we're currently, the HAPPEN investigation is about 2,400 participants in 4 different sites where we are actually taking pregnant mothers and enrolling them in similar studies and following them longitudinally with the aim of understanding and identifying those subgroups that might be protected from air pollution or recurrent respiratory infections or asthma across the lifespan. But really birth cohorts are the gold standard for that work, and lung disease to date has actually really looked at injury distally and sort of looking at risk factors a priori.
Dr. Punjabi, do you have a question? Maybe he can't unmute himself.
He posted them in the chat.
Maybe Dr. Lakakis, maybe ask yours while he's...
Yeah, so in the CAT scan, I noticed some big cysts, air cysts. So is it possible that this person had any cystic bullous disease of the lungs?
Yeah,
yeah.
Yeah, and I think the classic example is Bert Hogg Dubé, which you sort of mentioned in the text. And so unfortunately, there's actually a study section, a study center in Bethesda that able to do the genomic analysis. He did not have any folliculomas for what it's worth, and his actual, I think his actual risk factor actually turned out to be prematurity at birth. But Bert, certainly screening for Bert Hogg Dubé in women lamb. As well as in individuals that are younger, cystic fibrosis, but he did not necessarily present as the typical Bert Hogg Dubé case.
Thank you.
Dr. Punjabi?
Trishul, how does environmental exposure to PM10, let's say, or PM2.5 modify biomass exposure effects? Is there data enough to take the stand that it may exacerbate, that it may modify, or is it just too complicated to to segregate PM2.5 effects from biomass? Because I bet that they're correlated, or at least exposure to high biomass is probably exposure to high PM stuff, correct?
Correct, and so the reason why we do studies in low and middle income settings is to really create sort of that high intensity or high exposure environment. The work in the United States, the classic example is sort of the adolescent cohorts out of LA that have shown increased rates of asthma with increased rates of ambient air pollution. Air pollution is air pollution, right? So PM10, PM2.5 can be found in ambient air pollution as well as household air pollution. To date, we believe that model is continuous. That exposure thresholds above the WHO standards, whether it be related to ambient air pollution or household air pollution, sort of is the same. But the study that I was mentioning that recently funded R01, where we're looking at migration and urbanization, will hopefully definitively answer that, because we will be able to look at both ambient air pollution, or personal air pollution, as well as migration back and forth over a 5-year timeline.
Dr. Kolber?
You showed for individuals with a low BMI that they had a poorer or more COPD, I guess, than those with a higher BMI. And is that secondary to protein wasting or increased biomass problems, as you had described, just because they're in lower socioeconomic conditions?
A combination of things, right? So you have to be careful as that the cross-sectional data, and so it's likely a combination of factors in high-income populations. And so the BOAT index by Barcelli's group utilized the Copenhagen heart study. In high-income settings, it's almost exclusively a result of end-stage COPD, and so individuals with end-stage COPD have a lower BMI. It's driven entirely by exactly what you're saying, cachexia from protein deficiency, but low and middle income settings, it probably is a combination of the two, right? And so it's probably a result of risk factors or malnutrition over the lifespan that resulted in decreased lung function attainment, as well as to some component COPD related cachexia. And so it's important to understand the context in this case, because there's obviously multiple risk factors that are concurrent.
Any other questions? Dr. Pawa?
Yeah, and so this is a great question, and actually I do not know the answers to this, and certainly someone else from the division.
Can Dr. Pawa at least unmute herself and read the question?
Well, I can just read it.
Okay.
That was a great talk. Thank you. I wanted to know if chemotherapy during childhood, such as bleomycin and radiation to chest, lead to compromised lung function in adulthood.
Yeah, and I do not know the specific evidence to that, but theoretically, yes, if an individual, both bleomycin and radiation result in fibrosis, and so theoretically that could carry on to adulthood, but I do not know the exact data for that.
Okay, well, I thank you once again, Trishul, for coming to Miami and for giving us this great lecture, and we look forward to interacting with you in the years to come in very meaningful ways. So thank you so much. Everyone have a safe day and be well.